Good afternoon. If you think that you are in the International Ballroom, concourse level, you are. And I'd like to welcome you. I'd like to ask for the presenters that are on the panel to please join me up here on the podium. I think you know who you are. Your PowerPoints are preloaded. Really hard to see the rest of you, but I do know that this is a much larger room than we would like in order to have some sense of community here. So I would like to take the chair's prerogative and ask all of you to please come and sit in the first few rows so that in fact we can engage after our presentation in a dialogue here. May I ask you to do that? I don't need to sit. Yeah, I'll pop up and down. Yeah, when the speaker, yeah. So if our presenters could kindly sit in the order that you're going to present, and we'll continue in the order that is in the panel here in the program. Thank you all very much for attending. It's a pleasure to have you here at this very successful first day of CUGH's conference. There is an amazing array of intellect, energy, capacity, and many people from around the world. And so it's been a very exciting first day for me, and I hope for many of you, and that will continue as such with this panel. So just to, again, orient you, you are in the session that is entitled Building Effective Global Health, Education, and Training Programs. I give a lot of credit to the organizers who put together such a great diversity in this panel. You will be able to read about their illustrious backgrounds through the program. I don't want to take time to do that. I want to give them the time to be able to make their presentations. I think you'll be pleasantly surprised to see that we're going to be talking about nursing. We're going to be talking about care for children. We'll hear about interprofessional training and disaster risk mitigation, humanitarian health worker, interprofessional team building. So really quite an array across the global health professions and in a variety of locations. I haven't introduced myself yet. My name is Dr. Jenny Samaan. I am with the Association of American Medical Colleges, and I am the director of a new international program that the AAMC has launched that is called Global Health Learning Opportunities. We're an exhibitor, and I invite you to come and take a look at our exhibit and chat with us if you don't yet know what we're all about. So I'd like to go ahead and introduce our first presenter, who will be Sarah Rominski. And as they come up, the PowerPoints will be coming on. We'll have each presenter give their 10-minute or so presentation, go through their slides, and then that should give us ample time at the end to see if there were some emerging themes and to turn to your questions and comments. So if I could ask Sarah to join us at the podium, we'll begin with... No? Okay, we've had a change of speakers, I guess.
I'm not Sarah, as you can tell. I'm actually a Nikofi. I'm an assistant professor in emergency medicine from the University of Colorado. It's my pleasure this afternoon to share with you some work that our team has been doing regarding the validation and the development of a trauma care assessment tool for emergency nurses in West Africa. I forgot to ask where the clicker is. Oh, here we go. I'm going to be presenting on behalf of a pretty accomplished team, so it's my pleasure, really. Suan Bell is about 5 feet tall and blonde and really pretty. I am obviously not Suan either, but I represent a sort of a wide variety of institutions here. So this work was funded through a MEPI award from the Phuoc International Center. Sorry, the mouse is just not responsive. So by way of introduction, it's no surprise to you all that the burden of acute disease is disproportionately large in sub-Saharan Africa. And I think no other condition has been a better poster child for the need for emergency care than trauma. We all know that emergency care occurs in a continuum, beginning from the pre-hospital setting, through the activation, the recognition and activation of emergency, through the provision of some sort of pre-hospital care, and culminating in a definitive care facility, ideally somewhere that can provide good in-hospital basic emergency care and some form of definitive care. And today we're going to be talking about a way of assessing the competency of nurses to provide such care as one aspect of strengthening the chain of survival, so the most distal portion of that spectrum. In 2005, the WHO gathered an international team of traumatologists and emergency care experts who came up with a matrix of essential trauma and skills appropriate for providers of all tiers in pre-hospital and in-hospital settings in low and middle income countries. So this was the foundation, the platform for the work I'm about to describe. Just by way of background, in Ghana specifically, emergency nursing training. Okay, great, thanks. So emergency nursing training has been ongoing in Ghana since 2012, and they graduated their first class late last year of a cohort of 24 nurses through a one-year diploma program. It was really a sandwich format where nurses were sponsored by their home institutions, would train for 2 weeks, in Kumasi, led by instructors through this MEPI, through the MEPI award, and ultimately they graduated with diplomas a couple of months ago. So the overarching objective of our work was really to develop an emergency nursing trauma care knowledge, attitudes, and skills assessment, minimum competency assessment tool. But in this presentation specifically, I'm going to be describing some of the preliminary results from the development and validation process and the first application of this tool as a pilot. So the first step in the methodology was really we assembled this this group of multinational experts in emergency nursing care who really sort of anchored all the constructs that were going to form this assessment tool using a modified Delphi approach. Experts hailed from Ghana, Ethiopia, Tanzania, Malawi, and South Africa. And there were 5 steps. Initially, the expert panel identified objectives and attributes, key attributes of this tool, such as local appropriateness, sustainability, easy to implement, and so on. And secondly, they narrowed the domain of this very broad WHO content by using a tool that we created where they would essentially pick an element such as assessing, the importance of assessing an airway, and the expert nurses would deem that, would score that in terms of relevance for an African setting. Third, the items that they deemed to be most relevant were operationalized into a survey instrument. Fourth, we reviewed these questions and we fine-tuned them for language and syntax. And then lastly, the instrument was pilot tested in Ghana. So I'm going to share some of those results with you now. So the subdomains from the broad WHO domain that were identified for inclusion in our assessment instrument included primary trauma assessment and management, secondary assessment and management, focused and ongoing trauma assessment, and then some various principles such as team-oriented practices, nursing analyses, and planning and implementation. So I'm going to share with you some just snapshots of each, just of one of several pages of each parts of these tools for you to get a flavor of what the tool looks like. So the first is really a demographics and intake section. This takes about 5 minutes for the nurses to complete. It includes, personal identifying information, including, prior work experience and educational history. The first real part of the tool is a written, hypothesis-based attitudes assessment where nurses would agree or disagree with statements we'd made. So there were 46 of these. The second part of the tool was a knowledge assessment, which was orally administered by an emergency nursing expert, to a student, and there were very focused questions that were asked, and based on the responses the student gave, the examiner would code them on this form. The third part was a skills assessment, which took the form of, I think, a well-known format in the US, which is the observed standardized clinical encounter, where there was a mannequin and an examiner and a student would present a scenario to the student, and the student would perform a task or a skill, and the examiner would, using this form, code whether or not the skill was performed competently or correctly or incorrectly. And there were approximately, in all, there were over 300 discrete knowledge elements that this tool extracted specifically about trauma care. I'm going to share with you some results from the application, the pilot application in Ghana, among this cohort of 24 emergency nurses. So the tool in general seemed to be easy to apply, clear and well understood, was appropriate for low resource testing, and most importantly, was able to discriminate knowledge, attitudes, and skills among this cohort. And these were evidenced by the following pieces of data. Like our responses in general were very favorable in the 4 to 5 score range. We scored lowest for an appropriate assessment duration only because it actually took about 10 hours from beginning to end for 3 examiners to assess a cohort of 24 nurses. And as I said before, there were over 300 discrete knowledge elements. So this is in fact a very robust, detailed assessment. The graph over here shows the spread of scores from the attitudes question. I put this up not to indicate the scores specifically, but to show you that the tool is able to discriminate, sort of a wide, variety of attitudes towards trauma care. The same is true for knowledge, where the tool is able to pick nurses with high versus low sort of trauma core knowledge. And then the same was also true for trauma care skills. And again, you'll see below that actually we just report the raw score, not a percentage, because we're actually still in the process of fine-tuning the denominator with which we'll use to score all these nurses. So in conclusion, I think we were able to successfully create, from what I've seen, the first time this has actually been done, at least in a sub-Saharan African setting, a tool which uses expert consensus to discriminate essential knowledge, attitudes, and skills among emergency nurses. And we were able to successfully apply this in Ghana, and the feedback we got was overwhelmingly positive. Our next steps, really in Ghana specifically, are to think about integrating this tool, after it's been refined, of course, as a long-term, sort of a longitudinal assessment tool, among subsequent classes of emergency nurses, and also to use it as a way to judge knowledge and skills retention of graduated nurses to see, how quickly their skills and knowledge, are degrading in the field. And then we plan on exporting this tool to other African settings, hopefully to validate them locally to ensure that they work there, pilot test the tool, and then hopefully deploy them in settings, of course, where there are emergency nurses being trained to assess their competency towards basic and essential trauma care. Ultimately, what we really envision is this tool will be sort of a standard measure across several African, sub-Saharan African settings, to measure these nurses, to provide sort of an apples-to-apples comparison, both as a snapshot in time and also longitudinally. So we have a way of globally, assessing the quality of emergency nurse knowledge, attitudes, and skills around essential trauma care. So with that, I would like to end. I don't know if we're taking questions now or at the end. Okay.
Thank you very much. We'll take questions at the end, if you all don't mind, to ensure that everybody on the panel has the opportunity to share their excellent work. So thank you so much for representing the work of your colleagues. I'd like to invite Bistra Zheleva to join us, and she's going to address the program for cardiac care for children in underserved regions. So we're going to perhaps go to a different geographic setting and certainly a different kind of focus. Thank you.
Thank you. I guess I have to wait for the slides to come up, but it's a great opportunity for me to be here, and I guess I'm probably the only non-medical person presenting to this. I come from Children's HeartLink. We're a nonprofit organization, NGO, based in Minneapolis, and we focus on building capacity in pediatric cardiac care in low-resource countries around the world. So today I'm going to present to you the model that we have for our work with partner hospitals in several different countries. First, I'd like to start with what our vision and goals are for our work. Our mission is really to increase access to pediatric cardiac care around the world for all children, by helping to develop in underserved areas of the world sustainable regional centers of excellence. And wherever possible, we would like to see those centers become also training sites themselves. Why do we do it? A lot of times you don't hear about pediatric cardiac care and pediatric cardiac services as a big healthcare priority. But in fact, congenital heart defects are actually, this is the most common birth defect around the world. 1 in 120 kids will be born with a congenital heart defect. And unfortunately, 90% of those newborns do not have access to adequate pediatric cardiac services. In addition to that, we also have the burden of rheumatic heart disease in many countries around the world, who also, many of those kids also require surgical services potentially in their lifetime. The needs that we try to serve are really universal. There is a shortage of trained medical personnel around the world. There's a shortage of centers who can provide pediatric cardiac services. Where there are centers, a lot of those have poor clinical outcomes. There's a poor morbidity and mortality. Most countries do not have coordinated plans about addressing congenital heart defects or rheumatic heart disease. And of course, there's an equal distribution of resources. So really our objectives are, I would say, the same in every country that we work. We currently work in 6 different countries where we have partnerships in China, Brazil, India, Malaysia, Vietnam, and Ukraine. Some of our guiding principles are really, would like to say that our number 1 priority is to save the lives of children, but we do that by supporting the development of sustainable centers, sustainable pediatric cardiac programs. And in our work, relationships and partnerships are really key to how we implement our programs. We would like to believe that understanding the context in which you work is very important. Again, that's one of our guiding principles. We actually have tailored capacity building approaches. So really we look at what the needs of our partner sites are and what is the best way to address them. Of course, we're committed to tracking progress and impact at our partner institutions. And we work in partnership, actually, to provide training and education with volunteer institutions from the developed countries. Of course, as any NGO, we'd like to be as efficient as possible and be good stewards of the funds of our donors. From looking at this, at our work from the perspective of the patient care continuum, if there's a patient with pediatric cardiac needs, we actually have 3 different areas that we try to address. One is really our core capacities working with hospitals that have pediatric cardiac programs. We also work in the communities that surround them to really support the linkages to those communities to our partner hospitals and improve referral and follow-up, for example. And we have recently started focusing a lot on what we call patient empowerment, so trying to develop patient and parent advocacy groups and improve patient education after their patients are discharged from the hospital. This is just a schematic to describe what our motto is. When we partner with a hospital that has a pediatric cardiac program, this is really a long-term commitment on our side. It takes many years to develop a well-functioning pediatric cardiac program, both surgically in terms of critical care, cardiology as well. you have to train a lot of different people, or really support their training and support the development of the services that they provide. We roughly divide this in 3 different phases, and those phases would lead to our partners becoming what we call global partners in care or global partners in care and training. Some of the examples of what we call clinical capacity building activities are really with the matched volunteer institution that our partner sites work with. There are a lot of exchanges in terms of training visits, both staff traveling to and from our partner site to visit and for training. We try to develop infection control and prevention systems. We try to offer distance learning opportunities. We try to help them develop quality monitoring and data collection systems. Strategic planning is something very important, teamwork, and really any activities that meet the needs of our partner sites and would lead to improved quality and improved access and higher volume of patients that they would be treating. Some of the measures that we use to see how successful we have been in the capacity building activities that we've been providing to our partner sites. In terms of a shorter term, we definitely look at quality measurement systems in place, dedicated intensive care unit, and critical care services for children, planning capacity in place so they know where they're going and what they want to do with their programs. Infection monitoring and prevention systems development. We definitely look at specific infection rate reduction. Even in the shorter term, we hope to see some mortality reduction in terms of the cases that they do. Team communication. Pediatric cardiac care is very much a team approach service, healthcare service. If healthcare professionals from different specialties and disciplines do not work well together, the outcomes really show that. And of course, we definitely look at clinical skills improvement based on the assessment of the medical volunteers that work with those professionals. On a longer term, we look at those same measures, but I would say we add increase in volume of the patients that they treat, mortality reduction, decrease of ICU length of stay, infection rates, again, reduction. And we look to them to start planning for becoming a regional center of excellence or regional trainer, really to that commitment. Of course, not every hospital would want to be that, but we try to address that in the initial selection of our partner sites. And of course, ongoing continuing education is another piece. If you want to be able and to be effective in training others regionally, you should be able to provide continuing education for your staff as well. This is just an example of a grid that we use, just the first page actually, of some of, in the different phases, what are the outcomes that we look for in our partner sites. It's really a menu of options that, because we have a tailored approach to the needs of the hospitals and the programs, we have to be flexible also with how we measure them. And this is just some examples of what we look for in terms of outcomes through the different phases when we work with a partner site. Another area that we actually recently started focusing a lot more in is what we call organizational capacity building. To build sustainable programs and to build sustainable centers of excellence, we have found that stronger organizations really help that process. So definitely having a good team having teams in place, obviously, and good mentoring services provided to new team members, leadership and administrative systems development, again, strategic planning, distance learning, telehealth systems. These are all aspects of the organization of this healthcare program, of this pediatric cardiac program, that are critical to them staying in business and knowing that they will continue to provide quality services in the future. This is a list of our current partner sites. I'm not going to go through all of them. And the list of the volunteer institutions that provide the training. Again, these are long-term partnerships, so the volunteers from these institutions really commit to a long-term training, education, and mentoring relationships that they provide to the Children's HeartLink partner sites. Some of the recent accomplishments, for example, all of our partner sites have been able to reach over 70,000 children. We have provided a number of training visits and experiences, off-site training experiences for our partners. And we have been able to train over 1,000 medical professionals. Our partner sites' clinical outcomes have improved in a number of different settings. And we recently actually named our first global partner in pediatric cardiac care and training, and have named 2 partner sites as global partners in care. I will go and give you just a few examples of how we've worked with some of our partner sites. This is a hospital it's a children's hospital in Ho Chi Minh City in Vietnam. We've been working with them since 2008. And these are some of the accomplishments that we've had with them over that period of time. They really have increased the the volume of the patients and complexity of open heart surgery that they have been able to do. They've actually significantly have increased the number of interventional cardiology procedures for congenital heart disease. They've been able to lower their mortality rate significantly to 3%. They've had significant reductions in their infection rates. And based on the assessment of our volunteers, they've had very good improvements in terms of the skills of their healthcare personnel. That goes for cardiology, nursing, cardiac surgery. Nurses have been able to undergo pediatric advanced life support training, which was the first time that was done in this country. And we were able to introduce a quality improvement system and database and measurement for them to track their results and outcomes. And some of the goals that we would continue focusing on, this is actually one of those sites that we hope to become a regional training center. And we hope that they would be able to provide assistance to other hospitals and to other programs in the region. As they they come from an academic institution. These other 2 examples, and I'll go very quickly through those. This kind of shows you through the phases of what we have been able to provide and what our expectations have been and the results have been of the assistance. This is a hospital, West China Hospital of Sichuan University. It's based in Chengdu, China. Again, a hospital that we've been working with since 2006, I'm sorry. And that another example of a hospital that is a candidate to become what we call a global partner in training. This is an example of hospital that we work with in Malaysia, in Kuala Lumpur, Malaysia. It's the National Heart Institute in Kuala Lumpur. Again, institution that has a very strong program and very well regarded regionally and nationally. So these are the reason why I'm showing these is I wanted you to see examples of not only the implementing approach that we have in terms of working with these institutions, but also that we are committed to tracking the results of the assistance that we provide to them and the capacity building services that we provide, and also the outcomes of our partners. And maybe. Thank you.
Thank you very much. We'll move on now to hearing about ethics and building a global health, teaching global health and using ethics for interprofessional training. Our next presenter is Phuoc Le from UC San Francisco here in the U.S.
All right, thank you. Is it okay if I not use the podium?
Of course.
Wonderful. We have kind of a nice...
Microphone for the recording.
Broke the rules. Alrighty. Still, since we can't get you guys to come up to the first and second row, I'm going to come down. Would you mind putting up the slides. Thank you very much. Hopefully I'll be really, really quick because I'd love to have some time to do a little bit of Q&A towards the end. But as we all know, the interest in global health is skyrocketing. I've seen some stats showing 90% of residents in some schools are interested in global health in one way or another. So we know that. The opportunities are also increasing. As we just, earlier I heard Dr. King Holmes from University of Washington show a graph that goes straight almost up like this in the last 10 years of universities offering global health programs. But the problem is that I feel like we're not, at least I wasn't, well preparing my trainees to go out into the field and actually face ethical dilemmas that are unique to that situation and that they're not prepared for it. And one of the appalling things that I've seen recently is this. And I hope you agree with me that there would be no way on this planet that in any of our institutions in the US or the global north that this would be tolerated. So in a recent survey of trainees in Uganda at Mulago Hospital, my colleagues at UCSF worked with Ugandan colleagues to do a survey. And they asked Ugandan trainees, residents in surgery and anesthesia, this question. I am uncomfortable with the ethics of some clinical decisions made by visiting faculty and trainees. Just take one guess. How much, if this were asked at UCSF, I would maybe tolerate 0.5%, 1%. It's a staggering 31%. If you're a trainee and you see 1 out of every 3, or if you've seen it, 1 out of every three trainees has seen something unethical being done by a foreign either faculty or trainee, that's a staggering number I think that we cannot accept. And this just came out in the journal Surgery. And I can easily send you that PDF if you're interested. So at UCSF, we got some small grant funding internally and developed a high fidelity simulation to teach global health ethics pre-departure. So what we did was we formed a committee of interprofessional faculty from the 3 schools that I mentioned earlier, medicine, pharmacy, and nursing. We conducted a relatively extensive literature review and collected all the different global health ethics curricula that were out there, including online modules like the one at Stanford, the one that Stanford supports. And then we conducted focus groups of faculty. So we brought faculty together who have global health experience from the three different schools and basically asked them what were the major ethical dilemmas and the types and specific examples that you actually came across when you were working in resource-poor settings. But we took those and we developed 8 different scenarios, real-life scenarios that people like me or more senior faculty have faced in the past 3 decades of work. We narrowed those down to do a pilot. So we took 4 of those scenarios. We then took actors from our simulation center. So at UCSF, we have this really, really nice simulation center. And what they usually do is they do mock codes and they do mock surgeries because you never want to do something for the first time on a real patient, right? So we took that setting and converted it into a resource-poor setting as much as we could, so it could be as high fidelity as possible, and we trained actors to play the roles. So we had piloted 27 of these sims with trainees from medicine, pharmacy, dentistry, and nursing, and from levels all the way from medical students to nursing, NP students, all the way to fellows that I train in global health. So the gamut, the spectrum of the levels of training. We did pre and post surveys and a focus group of participants afterwards. I'll show you some pictures. So here's the high fidelity sim center. It's called the Canbar Center for Simulation at UCSF. So we took this and converted it through the power of Amazon to this setting. And you can imagine this. We turned the lights down, except the spotlight is on this little hut, kind of. And we put background noise of chickens and kids playing soccer. And we bring the trainees in groups, interprofessional groups, groups of 4. So you'd have one MD student, one RN student, one pharmacy student, and they're working together as part of the simulation, but one person takes the lead and the other people stand back and observe. And we ask those people who are observing to jot down notes, what would they be doing if they were in the lead? And this lady with the white coat is a community health worker, and they're visiting a woman who is in their HIV program, who's pregnant and is now in obstructed labor. So this is now 48 hours into obstructed labor. There is the pediatrics resident there, and next to her is a nursing student. And there you go. You have now 10 minutes to ask questions to figure out what you would do, and they are under a lot of pressure. This is all being recorded, by the way. So I am in the back room with 8 different camera shots, seeing all of this, and it's all being recorded. And after 10 minutes, after the sweat is all the way down to their chest from their foreheads, we stop and we immediately do a debrief. We sit down and we have a faculty person who's trained in ethics sit down with them, all of it being recorded, and spend 15 minutes talking about what others would have done in the group, what others could have done, and basically a different approach. And we try to emphasize that there's no right or wrong answer, as we all know, but the important approach is that you think broadly about the consequences of your action, of your decision, that the stakeholders are not just the patient and yourself, or just the patient and the community health worker, but really the larger community. And then we try to teach the fact that maybe you don't have to make a decision on the spot. Maybe there should be somebody that you can turn to. So those are some of the take-home things. And so far, it seemed to work. And so we had an N of 27, and with of course, just the pre and post test, which really don't count in my mind for that much in terms of calling this a success, but the post tests were very favorable. We then did a focus group amongst about 8 or 9 of the participants, and some of the quotes from the focus groups were really compelling. Arguing doctor simulation was so nerve-wracking, it felt very real. So there was another simulation where there were 2 physicians arguing about a corruption case. And then I highlight the last quote because it shows that an interprofessional training is useful because you're bringing in people from different perspectives. And from the nursing perspective, they can be teaching the physician or the pharmacist teaching the nurse, etc. So the conclusions here, and I'd love to get some questions from you at the end and feedback as well, is that our goals were really to expose trainees before they leave to ethical dilemmas and to reflect on their decisions that they made in the simulation so that when they're actually in resource-poor settings, hopefully their decisions will be much more informed. And next steps, so the trainees are now in the field, and hopefully when they all come back, we'll do a real evaluation of the curriculum. We would love to, and I'm planning to integrate these into many more pre-departure trainings as part of UME and GME global health programs, and sharing it with others, and expanding the use of high-fidelity global health simulations in pre-departure training, not just for ethics. And in terms of sharing the curriculum with others, one very interesting thing that I learned from this study that I mentioned earlier was that not only did 30% of Ugandan trainees say that they have seen a foreign faculty trainee do something unethical, but 30% also said that they've seen a Ugandan faculty person do something unethical. So I think it's not necessary. This is potentially something that can be used not just for pre-departure training in the US for our trainees, but can be adapted in other settings as well. And that's it. Thank you.
Thank you very much. I'm sure we're going to have many questions in follow-up when we finish with the rest of our presenters. So I'd like to invite Janet Lin, please, up to the podium from the University of Illinois at Chicago. And she's going to share with us a modular community-informed disaster reduction, disaster risk reduction. So we'll hear a little bit from her. And that's how you can advance your slides with the green arrow.
Perfect. Thank you.
Thank you.
Good afternoon. Thank you for being here this afternoon on our first day. I'm very happy to be able to present this ongoing work that we've been doing for the past 4 or 5 years in Haiti. So the academic title is Acceptability of a Modular Community-Informed Disaster Risk Reduction Training Program in Delmas, Haiti. Very long-winded, very appropriate for the academic audience. But another more simple way of doing it is really what we're trying to get at is why should someone like this care in that setting? So really, I mean, that's really the question, and that's the work that we're really trying to do. Yeah, okay, sorry. So, I mean, I am certain most of you are aware of the recent series of disasters that have been stricken Haiti. In 2010, there was the earthquake. In 2010, in October, there was also the new cholera epidemic that began in Haiti as well as a result of both earthquake, destruction of infrastructure, and also other influences as well. And it doesn't just stop there. There are, continual annual storms and disasters in many ways that they face yearly. So in 2012, there were regional droughts and 2 major tropical storms that not only devastated the agricultural infrastructure, but also put a lot of these people who are already vulnerable into food insecurity. So in terms of the rationale of what we want to do, it makes sense. So what I'd like to do this afternoon is really kind of define what disaster risk reduction is, review our timeline of progress in terms of the work that we've been doing there, and also discuss some of the findings that we've found with this community-based training. So a lot of people understand disaster response, and disaster risk reduction is actually much broader than that. It goes beyond just the disaster response. Many of us who are emergency medicine trained, I mean, we understand that. We go in acutely to respond to a disaster. But once you get through that initial acute phase, there's much more beyond that. So disaster risk reduction really goes beyond that. So the intention of this is not only just to respond, but also to reduce the exposure to hazards that will always exist, to lessen the vulnerability, to manage land and environmental resources, to be able to address that, and to improve preparedness in general. And a lot of this is based on the HeartLink framework, which in a very, very short snippet really labels 5 priorities for action in regards to disaster risk reduction. And these are guiding principles and means to achieve disaster resilience, such that not that response is not going to be required, but that the response needed is not going to be as large. So this is just a graph of the 5 different thematic areas, and where we've been focusing on are these 2 that you see the arrows in: risk assessment and increasing knowledge and education. So what we've been working on is something called a community engagement disaster risk reduction in Haiti. And this is just outside of the area where we've been working in. To give you a perspective, we are right in Port-au-Prince, in one of the communes in Port-au-Prince. We've been working primarily in Delmas, but most recently have expanded to another neighborhood in Port-au-Prince as well. Our timeline, as I've mentioned, we've been there now for about 4 or 5 years. We started initially with a disaster preparedness assessment, and then created some activities geared towards the community level. Vetted those, which actually informed our curriculum development, and then we've been able to actually now preliminary test adaptability of this curriculum with another neighborhood. So first and foremost, I mean, I had been in Haiti only just after the earthquake, responded in the acute disaster response, but my formative background really was working at that community level, working with health promoters and really trying to understand how can you actually improve, whether it's access to care, delivery of care, understanding at that community level. So it's very important to understand that community. As it was just an introduction, we decided to do a community disaster preparedness assessment. And where we concentrated was this neighborhood in Port-au-Prince called Delmas. And what we did was an assessment of not only the community, but also the clinic around which we were working with and the local government. So within each commune in Port-au-Prince, there is a mayor's office, a local government that has pretty independent oversight over that commune. So we really engaged them. And we did a survey within Delmas. And our aim was to try to bridge this gap between knowledge and practice in disaster preparedness that we had kind of heard of. So just basic kind of results from this, which really informed the further development. You know, from our key informants, which were primarily from the local government. We had the mayor, we had the civil protection officer, who is essentially the person that's responsible for disaster response, and some health professionals really inform us. What they identified was that there was a lack of coordination from external agencies. There were significant resource and infrastructure deficiencies that they already knew about. They did recognize a need to disseminate education and training, and they felt that they should be in that position to be able to provide disaster response, but then also potentially the repository for education and training. On the corollary, the major themes from the community survey really looked at the fact that there really was no infrastructure. They had not seen any type of disaster response. They've not received any type of training of any sort. On the positive side, what they did have, and this is, if anybody has worked in Haiti, I think people are very much aware, is that they have very strong social and family support networks. And so that's what we had to work with. Once we decided that, what we determined was we wanted to try to create a program that was really geared towards the community level. So we wanted to test certain activities that could teach disaster risk reduction to community members that had very basic education levels. And we wanted to assess these activities for, one, the acceptability of the method, but then also, were we able to teach what we wanted to teach them? So knowledge acquisition. And we had very good results. I mean, almost, I wouldn't say 100%, but I mean, predominantly, a majority of them were able to understand what we were trying to teach and actually found them fun and interesting and not something where they were sitting in a classroom trying to learn, but very dynamic. There were things like we did a resource web. We did examples in terms of trying to communicate, the human knot. Telephone, if you may remember as you were a child, in terms of trying to teach the importance of communication and accurate communication. So such things like that. From there, once we vetted the activities, we created a disaster risk reduction training program. And once we created that, we obviously had to test it. So this was essentially phase 3 on our timeline. And we created this in between that time frame, but between June and July of 2013, so a little under a year ago, we created this training program. And we designed it to be modular, such that it was divided into 3 primary content domains. It was really community informed. So once we got the activities feedback, we did some focus groups to try to see what is it that they really want to hear, how is it that we were going to be able to teach them, what worked and what did not. And so the training, again, occurred in Delmas, and we did it over 5 days, and there were basically 4.5-hour trainings per day. So one of the content domains initially was to define hazards, risks, and vulnerabilities. So what we wanted to do was define these terms. Many people have heard them, many people understand them, but do they really know what that definition is and what do each one of those mean? And we wanted them to understand the impact of common disasters that they see. So we worked with them to identify their own risks, hazards, and vulnerabilities, but then also to define the disasters that they see in their own environment. And it's not just natural disasters. They brought up issues of violence. They brought up issues of motor vehicle accidents, which are things that they probably see more in their day-to-day life than they see maybe in the seasonal environmental hazards. The other thing we wanted to talk to them about is this concept of a disaster cycle, that there is some predictability in terms of how these things work, and that helps to speak to preparedness and what they can do and actually look into what their assets were. The second content domain was looking at, we identify the risks, but there's also positives. So you wanted to look at identifying protective factors and community assets. So how we did this was we implemented a community mapping exercise and risk assessment. And in addition to that is actually identifying those protective factors. How can they deal with stress themselves and recognize coping mechanisms that exist in their own community, within their own family, within their own neighborhood? The other thing that we incorporated was something called photo voice. And really what this is actually handing cameras out to them or using their cell phones that many of them had and going out to their environment to actually take pictures of what they understood as the hazards, vulnerabilities, and risks, but also the protective factors in their assets. And so people came back with pictures of a church. They came back with pictures of a school. They came back with murals of paintings of people kind of telling their story. So there's multiple different things. We also saw a lot of the negatives, I guess you can say, a pile of rubble, a road that was still not fixed, whatnot. And then our third component was trying to develop these community engagement strategies to assess, mitigate, and manage environmental threats. What does that mean? Primarily, it's trying to get them to think about, now they understand what the disasters, risks, vulnerabilities, hazards are. They can see what their assets are and what mechanisms that they have even within their own environment. And we wanted to get them to think about what can they do. That they were not incapacitated because someone did not respond, but they had a lot of capacity to be able to respond themselves. So we had them create household emergency action plans. This image on your right is actually an example of one of our participants. And what we actually asked, what, who, how, where, why, and when. In terms of they had to think through what is it that they wanted to do, who would be involved in thinking through those steps for themselves. Beyond that, we wanted them to develop next step action plans. So to think beyond the training that they received, what can they do within their community? Now with the skills that they're equipped with, what else can they do? And we tried to teach them effective facilitation. The aim of our program is not just to stop there, but to actually train these people as leaders in their community that then they can actually spread the word and to teach other people within their community to do. So results in terms of our training program itself, we had 42 people that we actually piloted the activities and vetted the activities with. Of those, we actually trained 16 of them. We incorporated a pre-test, post-test knowledge acquisition survey, but we also did daily acceptability surveys. So we really discussed with them real time, what do they like, what do they not, what do they think that they could change, or what would make this program even better real time so that we could actually actively alter our program as it was going on. In terms of pre-test, post-tests, you can kind of see in terms of their ability to define the terms and also their ability to identify the reason for a community assessment and also the ability to identify assets all increased through the 5-day training. Realizing that this is 5-day training, we did also do a 6-month follow-up with them, and many of them had actually retained their skills, but also had actually actioned their next step action plans as well. The other component that we looked at in terms of results was acceptability of the training that they got. And between 80 and 100% showed that they thought the topics were relevant, that the topics and the activities actually provided them the skills that were useful to them, that they would actually be willing to share this with other people, and that they learned something new. I mean, knowing that there's multiple different organizations coming through, are we actually doing something that's innovative and new for them? Additional outcomes that we had from this training program, like I mentioned, 100% participants developed specific next step action plans, and the majority of them have actually 6 months later carried them out. We developed some new partnerships, specifically with a local Haitian school of social work, whom we really partnered with to actually introduce mental health training. And we actually worked with Haitian research assistants. They actually assisted us with the logistics of training and also data entry. And it was really a nice bilateral partnership in having the Haitian research assistants learning about research, but then also getting involved as well. And in addition, our translators themselves took the initiative to further the program. So in terms of that, in terms of success, we see the pre-test, post-test, like I said, it's very short term. Looks great. But I think the testament to success is really how do the people that have actually been trained translated this. And this is just an example. This group that you see here, there were 4 of the participants of the 16 participants, after they participated in this, actually created their own organization. They call themselves GTRID, Groupe Cap Travail pour Réduction Risque Actes, which is Creole for essentially a group that's working to reduce risks to disasters. They created their organization. They created their own T-shirts, a logo, a Facebook page, whatnot. They've done 2 trainings to date of their own community members, and they've had 62 participants in both of those. And they've also continued to try to forge new partnerships with other groups of people within Haiti. Recently, they actually just notified via their Facebook page that they're actually doing another training. So I mean, this is really when we can see, is it successful? The pre-test, post-test looks good on paper, but this is in real life when we actually see that these people have actually translated what we've taught them and taken it for themselves and really are working with us to say, this is what we need, this is what we don't, can you actually help us with this a little bit more? That's really true community engagement. So our next steps, and we're planning on continuing to work with these organizations and really make it bilateral and if not multilateral, is to incorporate some of the identified training needs that the community members have identified. First aid, mental health, women's health, and also to expand it beyond just the Delmas community. Like I mentioned in March, we were there just a month or 2 ago, and we actually trained another community, Bel Air. And the reason for that was one of the translators is that's the neighborhood in which he came from, and said, this is phenomenal. We need to actually bring this. We have a lot of young people in our neighborhood, and we're not getting the response from the government. Can you help us? So, we've gotten those responses, and we really want to test that adaptability and the ability to expand. And our other aim, hopefully, is to be able to create a more robust training manual such that when it does expand, that we're able to actually pass that on. We can actually pass that on to the community members to take for themselves. And this is just an image of our March training of our entire team. So a combination of both Haitians from Delmas, Bel Air, Tabar, which is another neighborhood, our translators, the School of Social Work, and our UIC team. Thank you.
Thank you very much. I'd like to invite David Tarantino up, please. He is from the Uniformed Services University, the Center for Disaster and Humanitarian Assistance, and keeping along the theme of knowing your community, working with your community, and building community engagement. We'll hear from him.
All right, hello everyone. It's great to be here. Thanks for coming. As mentioned, I'm Dave Tarantino. I work at the Uniformed Services University of Health Science. That's the military medical school. And there we have a Center for Disaster and Humanitarian Assistance Medicine, which is really a center for global health. And we do a lot of education and training and research and evaluation. And we actually conduct and support global health programs as well. We have been engaged in what we call the Defense Medical Language Initiative. It's funded by the Defense Language and National Security Education Office to look at health culture and communication. Here's the team that's been working on this project, and I'm going to tell you a little bit of our efforts, but really this all started with, first of all, you may be wondering why is the military even involved in this? What do we have to do with global health? Well, we've been increasingly involved in global health engagements, as we call them, and this is medical security cooperation, where we work with partner nations to build relationships and promote trust and interoperability with foreign militaries. We work with foreign militaries to build their capacities, their medical and health capacities. We work on disaster response in certain settings. And then sometimes even in counterinsurgency, stabilization, reconstruction, we are called upon to provide health support, and in fact required to by law of armed conflict, Geneva Conventions, and others. But we found more and more that all these activities require us as health professionals to really understand the health context of where we're engaging. And we use this as an example sometimes. Even one of the greatest health philanthropists in the world, Bill Gates, through a casual gesture, these were front page stories in South Korea that he had insulted the South Koreans with his casual greeting of the president there. For us in the military, this plays out when we go into villages or we meet with village elders. You never get a second chance to make your first impression. And for us, missteps like this can lead to mission failure, but also death or attacks or other things which are more serious even than a bad headline. So our program was meant to recognize the critical role of culture and language communication skills, and this applies. We recognize a lot in Iraq and Afghanistan that cultural issues are really essential in understanding the cultural context, but we're taking that to the health-specific considerations, which we haven't seen done as much as we need to train our people. You know, in the US, we have the class standards, the culturally, linguistically appropriate services standards that you're required to adhere to if you're providing services in the US. But there aren't really such standards in the international setting. And we've been looking for some guidance and training to help inform our health engagements. So we did a literature review, document reviews, we conducted a number of surveys and held some conferences and symposium. And then we began developing some curriculum. We developed sort of an introduction to health, culture, and language for our personnel, just a basic introductory course. And then we started to realize that the health culture is really important, but also the cross-cultural health communication, and frequently that involves health interpreters, for which there isn't a lot of experience or products or curriculum out there on training in that area to work to optimally utilize health interpreters. So we developed curriculum on that, and we're training our people now. And then we realized that it goes even further than that. You have to understand the entire health context, which includes culture and language and communication. But we also found that we wanted to find a resource or a reference where it would all be one-stop shopping, where all the health context information would be available. And we looked at a number of products, a number of sources, and this is a non-rigorous, just sort of in-house tool we developed. The domains were all the areas that we felt were important for us to understand if we're going to engage in a country. And we looked at different sources. NCMI is the National Center for Medical Intelligence, and they have a lot of useful information. But you can see, and I blacked out some of these just so we don't get an argument about, well, I work for that place and ours is better on this than you say. This is informal. But we didn't find anything that really met all our needs. And of course, on the last column, our goal is to have a source or a template or a framework that checks all these boxes so our people will go in with advanced knowledge and understanding. And so we came up with a construct of the health context, which to us is the cumulative influence of the country context, which is history, geopolitics, security, then the social cultural background, then the health culture, health-specific cultural considerations. Of course, determinants of health, and then the health system characteristics. We found that the last one, we put it there last, health system, that's most commonly what people will study up or analyze or get smart on, but for us, there's a whole lot more to it than that. And this construct provides a holistic understanding of the health environment, which is essential to our health engagements. This is how we represent it visually, graphically. The health context considers all these overlapping characteristics. And so we set out to develop a framework, a template for this, and we've been developing curriculum, short courses, and then much longer courses that we're starting to design for academic credit. And we use this framework to give our people understanding of root causes of problems or challenges, capacity gaps, country needs, appropriate opportunities for intervention. And so we're working smarter, hopefully, when we engage in health in other countries. And our big rationale is to do no harm. We know that damage by applying contextually inappropriate programs can be severe to our mission priorities and even to safety, and the stakes are high. You can get unintended consequences, undesirable outcomes, can jeopardize mission success. Now, I'm talking a little bit from a military perspective, but we think a lot of this applies obviously outside the military as well. Here's one example from the GAO, the General Accountability Office report said European command officials said DoD built a hospice care center for HIV/AIDS patients in a town in Ukraine. It was received negatively based on community's perspective of the disease. Officials said these cultural sensitivities were not considered, so the community was not supportive. The project did not provide European command with the goal of gaining access and influence in the Ukraine. That's ripped from the headlines. I mean, you can see one of the reasons we do these activities is so we can have access and influence, positive relationships, and because of not understanding the context, not understanding cultural considerations, that project didn't work. So we developed this context, which is a framework, a template. It includes the geopolitical, political, economic, security considerations. All of these can impact health and healthcare. I don't think I need to belabor that, but we look at security, governance, type of government, stability, how is the Ministry of Health structured, human security. And it's clear that the relationship between the state and society and the rights the citizens have influences access to healthcare, the government effectiveness and the stability of the government affects the quality of public services. And then we provide sources for this. This is a very narrow distillation of our work. This template is much more detailed, but just some examples of some of the sources that we steer our people to is you can see there. Social cultural considerations, we want our people to think about the social cultural context, history, customs, traditions, nationality, race, religion, gender, politics, socioeconomics. All of these issues influence health in terms of people's beliefs and attitudes. And there's some good information available, some sources that we relate people to. And we build into the template and the framework and the training some specific indicators or specific facts or specific metrics that we want them to understand in these areas. But also, so some of it's quantitative, but a lot of it is qualitative as well. And there's some of the sources that we steer people toward. Health-specific cultural considerations. We spend a lot of time on this. We've developed a whole separate curriculum just on this, but we build this in here too. This varies obviously around the world and even within countries, within localities, perceptions of illness versus wellness, disease concepts, health-seeking behavior, traditional folk healers. This is the hardest information to get. It's not readily packaged in a lot of places. You can go to some medical anthropology literature. There's some information online. The real source that we found you have to go to is expatriates or locals, and when we're working with our interpreters, that's the value of using local health interpreters, that they can be conduits of this information for you. We're developing a semi-structured interview template to get to some of the root information. It's the core information about health-specific culture in a given locality, but this is a hard area to really drill into. Determinants of health, burden of disease, this is much easier. There's a lot of quantitative data out there about disease patterns, mortality, morbidity, burden of disease, social determinants of health. You clearly need to understand all this if you're going to engage and be working on global health efforts. A lot of good information is available out there. There's so much of it that we're trying to teach our people how to weed through all that and get to some of the real core qualitative and quantitative sort of measures to understand this and make sense of it. And then finally, the health systems. This is the easiest concept to understand, is how is the health system organized. However, oftentimes we need to emphasize to our people that it's not just one health system. It's an overlapping system of systems. There may be the public system, there may be the private system that operates in conjunction with the public system in the afternoons. There may be a traditional folk medicine system. Non-governmental organizations may have systems in place. And then the military, for us, the security forces, how is their health system organized? Oftentimes that may be up to 20% of the health system of a given country. And we saw that in Iraq. And when the health system there, when the military was disbanded, that took away 20% of the health capacity in Iraq as well, because that was their health system. So we teach the 6 building block framework from WHO, and there's a lot of information from WHO, the World Bank, ministries of health themselves. People often overlook the fact that you can actually go to those sources on their websites or in person. So I'll just skip ahead to, so we think this framework is going to better inform our people in terms of how to understand the health context, better inform their engagements, provide critical knowledge, so we're going to get better efficiency and strategic impact of our engagements. So far, we've applied this framework in detail to Iraq and Afghanistan. At our center, we have some Iraq and Afghanistan expatriate physicians, and we have applied this in detail. So we have hundreds of pages now of detailed analysis of the health context of Afghanistan and Iraq. And we developed that into curriculum, which we're training people who are deploying to Afghanistan. And we continue to validate this internally and externally. We've been working with George Washington University and UC Irvine, a medical anthropologist. But we're incorporating this into training for people deploying to Afghanistan and Honduras, and we're getting very good feedback. The way ahead, we're going to continue to refine this health context analysis framework, integrate it into our curriculum, continue to refine and validate it. This summer also, if anyone's interested, we'll be having a health, culture, and communication symposium where we did this a year and a half ago. We're going to look at our findings, but we want to hear what others are doing in terms of practices for health culture and working with interpreters and understanding the context, and maybe consider some standards and practices, and then just promote a community of interest. So we'll take questions at the end there, but thank you very much.
Thank you very much. And last but certainly not least, but keeping in line with the concept of global disaster response, I'd like to introduce Hilary Cranmer, who is from Mass General Hospital here. And then after her presentation, we'll take questions for everyone. Thank you.
Great, thank you. So I have the pleasure of being the last person up. And the motivation is that in about 14 minutes, there's free booze. So if you're patient, you will be rewarded. So I have a very long title. Please feel free to read the title at your leisure. But I'd like to say that global disaster response is basically the gateway drug to global health. What I mean by this is that we've got the sexy part. I've heard a lot about disaster response. I've worked with several, in fact, a lot of you in disaster response in settings all over the world. And it puts your foot in a place that's uncomfortable, but hopefully makes the footprint deeper and stronger for those that you leave behind with enhanced capacity building, training, education, cultural competency, pediatric cardiac surgery, all these things that we've been learning about today, and certainly wrapping it up with how do we hold ourselves accountable. But that's for another day. So I present this abstract, and my deputy director's in the audience as well, Miriam, and I direct you to this slide that is obviously hard to read on purpose. The overall gist is that there's an increase in natural disasters, and we've talked about planetary change in this conference. We've also talked about other reasons why these natural disasters are occurring. So as you can read this from left to right, natural disasters are on the rise. The red line is important, and it's showing us that the mortality due to natural disasters is actually on the decline. Yay! We have preparedness, we have risk mitigation, we have, hello, there's a typhoon coming! Evacuate. So we've learned some of our preparedness works. So that red line's important. There are less people dying from disasters, and not from necessarily the immediate impact, but the subsequent impact of living in a disaster. But what's also important about this graphic is that from left to right, you see a rise in the number of people who are affected by disasters. So they're surviving, and they're surviving in places where they need water and food and shelter and livelihoods, and all those things that we recognize as being our standards. This is from CEDM, not from CEDM, from CRED, in case you needed to know about that. So we also know, PAHO has told us, and we understand that there are predictable needs in disasters. And I think that we as healthcare providers of global health, no matter where we are trying to provide global health, you will be affected by a disaster, whether it is in that room of the person giving birth and doctors screaming at each other, which I consider a disaster, to global disasters where hundreds of thousands, if not millions, are affected or displaced. And we are aware that these natural disasters, because they're increasing in frequency, we can predict perhaps and even preposition our resources. And like we have seen over the last 10 years, these disasters, like in Haiti, Haiti just happens to be very close, but also very vulnerable. We've seen almost nearly every part of these disasters there. And fortunately for us, we can hopefully have an impact on the community. Through these disasters, we want to have the lessons learned. We go from left to right, from this is not acceptable in terms of a field hospital or a displaced person's camp, to what is acceptable, what is right, and what is up to standard. We can do this by training our providers, not only sitting their butts in seats in a very nice city, but through enhanced capacity building, in distance learning, going to where the disasters happen in the South more frequently and more people in the South are affected. We can train them to these practices through competency word, that's it, okay. The knowledge and the skills and the behaviors, and then go back and say it's not just about what you're learning on paper, but it's actually how to practice it through simulation, through guided mentorship, through distance learning. We know we can do this, and we can do this right. These are pictures from the Haiti earthquake, and on the right is one of the largest field hospitals in Haiti that served over 6,000 Haitians. So what have we come to? In November, the Global Health Cluster, working from the WHO working group on foreign medical teams, came out with a classification for foreign medical teams. Okay, we're not just about doctors and nurses and pharmacists and hopefully some massage therapists coming to help in disasters, but we actually have to be able to say that we're going to be there. We're going to promise to provide what we say we provide, and we're not going to leave right away after 5 days. Okay, and it's not just about trauma care, it's about obstetrical care, and it's also about accountability and taking care of those people who provide in disasters when they come home. This is a great book, by the way. We did a little experiment at Mass General, which was, let's sit together and figure out how we can send people in an organized structure to places of disaster where they may be needed, whether it's an individual or a team, and what skill sets they need, what competencies they should have so that they can provide effective care. And we're working at the professional level. We already are doctors and nurses and respiratory therapists that know how to take care of patients in a very high standard of care area. How do we take care of patients in places where we don't have that standard available? And then how do you make decisions around that and then accept your decisions, and then how are you accountable? So with our combined experience, which is maybe a little bit more than this much, we've kind of got together and thought about what we needed on this team. Mass General Hospital is a hospital that is the largest teaching hospital of Harvard, but it also happens to have 24,000 employees, 23,999 of which want to go help in disasters. Maybe one person will stay home and watch the shop, but that's true. We had to figure out how to send people, whether they were deployed in a military traditional fashion, like through the IMCERT or DMAT teams, or through a global disaster response team. We had to make sure that we did not diminish the capacity of the hospital in Boston, where we have disasters in Boston once in a while. So we created a checklist, and we looked at all these organizations and understood, well, how do you decide to deploy? How do you make sure that someone's credentialed? I know you're a nurse, and I know you've been a nurse for 25 years, but when did you put an IV in? We had to find out. So we had to understand what their competencies were in practice as well as what they said they were. We had to be able to say, I sign off on these people. We had to make sure that they were prepared before they went, and then when they came back, what they learned from it so that we could send other teams, and then what kind of organizational support are available. Mass General is a place that actually has a humanitarian leave policy that you are paid for 2 weeks, and the third week you can use earned time. We ask that there's a 21-day minimal deployment. So there are large variations with other and between other organizations. We recognize that the credentialing process, and all of you who probably tried to go for a new job and take about 2 weeks to fill out the paperwork, and it can only be in ink and not a document signed electronically, you understand that it's sometimes difficult to do this. And I admit, as a doctor, I'm the highest maintenance person in a disaster, as well as filling out paperwork. We also have to understand that the definition of this skill set, nurse practitioner or a physician assistant, isn't necessarily understood in other realms where we practice and help with disaster response. And we also have to understand how we implement these deployments. So with the checklist, we wanted to have some minimum standards of deployment because we recognized that for example, with the Philippines deployment, we had over 400 people immediately respond that they were immediately available for 21 days. And to get 400 people on an airplane to the Philippines in Tacloban where there's no place to stay, I think is logistically impossible. But what we understood is that we couldn't send folks that perhaps needed a medical equipment to sleep at night to put them into tents. We also had to understand that they needed to be independent for a few weeks from food and water and housing supplies that may not be available in disasters. We also had to understand that they needed a team support because they were going to see things that were terrible, and how to help them through that and how to make decisions when we weren't there to help and stand there. We also had to, when they came back, make sure that they were debriefed and understood their resources as well as their support from the organization and whether or not they would be paid. So we believe that what we're doing at Mass General by helping to define some minimum standards that others can use them, that we can apply them through foreign medical team guidelines, and we can help others develop programs like this because everyone wants to help. We saw this in every single disaster, but it's our job as the trainers, as the educators, to capacity build so that we can let them help effectively, and that when they leave the disaster, that the people that they leave can actually continue to care for themselves better, because we're going to leave them there, and they're going to stay and then deal with the next disaster. Thank you.
Thank you very much. You were promised a diversity of projects, programs, and ideas that I think have been well illustrated. But in addition, I think there were some very repeated themes: competency, ethics, community engagement, and appropriateness of effort to the context and the country and the place and the people that people were engaged in. We know that at 6:30 we have a lovely reception awaiting us, but we would like to give you an opportunity to engage, to ask questions, to make some comments to the panelists. I'd ask that you please go to the center microphone, and if you'd like to ask it to a specific panelist, please address them, or if you'd like multiple speakers to address your question or your comment, please indicate such.
My name is Gabrielle Jacque. I'm from Boston University. My question is for Dr. Cranmer, particularly regarding the program that you have. It sounds really amazing and robust. How is it funded in the whole program in general, but also the humanitarian leave policy? Thank you.
Does this work? It comes down to the money, doesn't it? Thank you for asking. So Mass General is unique in having this policy. But with its relationships with the government, with DMAT and IMCERT teams, every hospital that has members on that team has signed a contract with the U.S. government to be able to support these members of these nationally deployed resources. So we kind of said, wow, well, if we can do that for our national teams, why can't we do it for our international teams? So what that required was actually getting leadership to buy into this policy. And this policy was created around large deployments with missions such as Project Hope, which is also considered a government resource in terms of supplying trained personnel in a very nice ship. But we've also developed it with using our other partners and NGOs, which is significantly important to have these partnerships to be able to provide the funding. So we're able to provide the resources, but our partnerships with NGOs provide the logistics, transport, housing, and often local personnel when needed. So this is it's an interesting partnership, but can be done, and it is actually much cheaper than you think it is. We had, for the Philippines, we deployed 27 people in 4 separate teams with 2 different NGOs for a total of 90 days, so 4 series of 21 with some overlapping, and it cost us approximately $350,000. Now, when you think about $250,000, it might be a lot, but when you're thinking about disaster response and the long-lasting programs that were established with the NGOs that remained in the area, I think it was a good gateway drug to that sustainable global health problem. Did I answer your question?
I want to thank all the panel members. It was a really interesting presentation. Dr. Lee, I wanted to ask specifically, if you could just give us examples of how you defined ethical global health issues, and maybe just an example. You showed us the case study of the woman in obstructed labor, but I wasn't sure exactly what was the ethical issue there. And also, are you able now to share those simulation scenarios? Because I'd love to get a copy.
Oh, sure. Very, very good question. We are trying to put this on MedEd portal, so I guess it's an open access online medical education website, and we're writing things up, and we're much more than happy to share. And in terms of cost, if somebody's going to ask, it's $25 per student. That's the base cost of how much it would be, and that's not including faculty time. But it could be a very cost-effective modality of education. In terms of the scenarios, so we had multiple themes. One was corruption, one was scope of practice, one was privacy concerns, and one was informed consent. So we had 8 different themes there. For the woman who was in obstructed labor, well, if you or I saw a woman with after 48 hours of labor and it's obstructed, we'd probably get her to a hospital so she can have a C-section. But in this setting, it was inappropriate because the husband was not there to allow it. And the husband was away, a week away, mother's having fevers now, so you're in a pickle. We created a really difficult situation, and that's where the high fidelity comes in, and these students really feel directly engaged, and they are literally under a lot of pressure, and so that's one of them. Another one is something that I faced when I was a resident, whether or not to put a needle into somebody's pericardial sac and suck out fluid to save somebody's life. That one was one of the most common scope of practice ones that we came across during our focus group. So all of them came from real life experiences of the faculty from those focus groups.
Hi, Dr. Ashkenazi from the Center for Global Health with Dr. Kramer. This is actually again for you, Dr. Lee. I'm just curious as to what kind of supervision the trainees have while in the field on their global health rotations. Thank you.
Yeah, so that's a fantastic question. It's something we grapple with. And it's for a place like UCSF, there are so many programs, so many different types and levels of trainees. So I direct a global health fellowship, so they're fully trained, residency trained, and yet I still send faculty out to supervise them. And for our non-residency trained folks, we try our very best to send them, if they're doing any clinical work, to a place that has either a local faculty person directly supervising them, or somebody affiliated with UCSF directly supervising. The problem is when people are not doing clinical work. Then it's much easier to say, okay, well, you're not going to be taking care of patients. You can go and if you have a problem, call me. So for example, research, people who spend a year doing research or programmatic work, those are the types of trainees who can potentially go to a patient's home, see something happen, and by virtue of their skin color or the name of the school they come from, they are suddenly the most capable person to take care of XYZ medical problem. So as part of our training, we definitely say, if you go somewhere and you don't have somebody to turn to, well, then you shouldn't be going in the first place, because UCSF should not be sending you to a place where you don't have a direct contact to call if something like this does occur.
I'm Brad Botig from the Uniformed Service University. Just a quick compliment and comment on Hillary's talk. I forgot your last name, sorry. Yeah, I really enjoyed it. I particularly like the quote you gave about disaster response being the gateway drug. The comment that I had is that your talk parallels, I think, perfectly, and I bet you Captain Tarantino would agree, what the military goes through in terms of all the things that have to be thought about with deploying to these things. And your briefing could be, rebranded U.S. Army and given and talked about how people need, we call it skills verification for everything from starting IVs to putting in different tubes in different places and things. And people need to be able to, live without their CPAPs and their own medications and things. So the parallels were just absolutely striking. But if you'll let me borrow your quote about disaster medicine being the gateway drug, I'll give you one of ours, and that is that, what do you say, amateurs are always talking strategy, but professionals talk logistics. So you could use that one when you give your briefing to the back at UMass. Thanks.
Thank you. Any other questions or comments for our panelists? If not, I hope you'll join me in thanking them all once again for excellent presentations.